Let's begin our session with Ummul Kitab Al-Fatiha. Okay, all right. So, who will be the first presenter? So this is TS2, TS3. Okay, so
TS2, Doctor.
TS2. Okay, all right. So who is the first presenter and which topic is it?
Me. The
Okay.
first presenter.
Yep. Falyatafaddal mashkura. Do you have your? Can you share your slide?
Want to see my slide?
Yes, yes.
So, Assalamualaikum warahmatullahi wabarakatuh. Very good morning. I bid to our lecturer at the site and also my colleague. So I am Afiqah. I will be presenting the first teaching seminar for today. The first topic will be an overview. An overview with children with special needs. So this is my outline for today. So we go to the first content, which is the definition. So children with special needs is defined as children with disabilities, severe chronic illnesses, congenital defects, and health-related educational and behavioral problems. This is as stated in Nelson. And in Malaysia, according to, we define a person with disability according to Person with Disabilities Act 2008, which is OKU is include those who have long-term physical, mental, intellectual, or sensory impairments, which is in interaction with various barriers may hinder their full and effective participation in society. So moving on to the epidemiology. So worldwide, according to WHO, World Health Organization, approximately there is 15% of world population live with some form of disability. So how about Malaysia? So in Malaysia, there is only it's estimated that 1.5% of total Malaysian population are estimated to be living in disability. This number is actually including this number include those not only children but also adult. So I'm sorry if there is background noise. So there's 453,258 persons who were registered as person with disability at the Department of Social Welfare Malaysia in 2017. This is the latest number that I can get, but actually this number is reflected lower because this is only the data the person who registered under the Department of Social Welfare. It might go more beyond this number. So this is the percentage of registration of person with disabilities by category. So the the Department of Social Welfare divided the person with disability further, divided into 7 categories, which are visually impaired, hearing impairment, physical impairment, learning disability, speech impairment, mental, and also multiple disability. So the highest number we can see, which is registered, is the physical disability. So moving on to the types of children with special needs. So this category was, as shown earlier, was divided by Ministry of Women, Family and Community Development, which we need to, which this category is made so that the person, it is easier for the person to be registered under the social welfare. So the first category is hearing, category of hearing. So hearing disabled means person unable to hear clearly in both ears without the use of hearing aid, or unable to hear at all with the use of a hearing aid. So the hearing disability can be divided into 4 levels, which is minimum 15 to less than 30 decibel in a child, moderate 30 to 60 decibel, severe, and also profound. So the next category is vision. Visually disabled means blind in both eye, or blind in one eye, or limited vision in both eye, or any other permanent visual impairment. So the visual disability can be divided into low vision, which is the vision is worse than 680 but equal to or better than 360, with use of visual aid or visual field that is less than 20 degree, or blindness means vision of less than 360 or a visual field of less than 10 degrees of fixation. Next category is speech. Speech disability means inability to speak that impairs proper communication and cannot be understood by those who interact with the person. So this condition must be permanent, and with regard to children, it is must based on assessment at age of 5 years and above. Only then the child can be categorized under speech disability. Next category is physical. Physical disability means the permanent inability of parts of the body, whether cause of loss or absence or inability of any part of the body that can affect their function in fully carrying out basic activity. This basic activity refers to self-care, movement, and changing position of the body. And then this condition can occur as a result of injury or trauma, or disease in either the nervous, cardiovascular, respiratory, hematology, immunology, urology, hepatobiliary, musculoskeletal, gynecology, and other systems that cause malfunction. Example of the malfunction are limb defect, including loss of thumb, spinal cord injury, stroke, traumatic brain injury, rheumatism, achondroplasia, and also cerebral palsy. And individuals who suffer impairment without jeopardizing their functional, for example, loss of finger or additional finger, or if the person does not have yellow or not fully formed yellow, it cannot be considered as registration purposes, as it is not jeopardizing their function. So the next category is learning difficulties, which mean the intellectual capabilities that do not conform with biological age. So those who fall within this category are the late global development, Down syndrome, and intellectual disability. And under this category also includes the condition that affect the learning ability of an individual, such as autism, attention deficit hyperactive disorder, and also specific learning difficulties such as dyslexia, dyscalculia, and also dysgraphia. The next category is mental disability, which refer to the state of severe mental illness that cause an inability to function in person, whether it's related to him or himself. And last category will be various multiple disability, which is the person having one or more type of disability from category 1 to 6. So as a physician, our role is to evaluate the children with the special needs. So the first thing we need to assess medically, which we need to identify the cause of developmental dysfunction, and we need to identify and interpret if there is any other medical condition that have the developmental impact. And then we need to have a comprehensive history and physical examination, which include a careful graphic growth parameters and also accurate description of the dysmorphic features. For the motor assessment, we need to do comprehensive neurology examination and also age-appropriate adaptive function evaluation by specialists and therapists. For psychological assessment, we need to test the cognitive ability and also evaluate the personality and also emotional well-being, and also to evaluate the IQ and mental age score. For education assessment, we need to evaluate area of specific strength and weakness in reading, spelling, written expression, and also mathematical skills, and also develop individualized educational plan, so IEP. So this IEP, this evaluation was taken from Nelson. Later, I will talk more about IEP, how IEP is conducted in Malaysia. So in Malaysia, we call it Inclusive Educational Plan. And we need to assess the social environment also, which we can do home visit to provide more comprehensive evaluation, suggest additional adaptive equipment or renovation at the house. And also, we need to refer local protection agency for suspected neglect and abuse. So in the end, our goal of management is to maximize the child potential for productive adult functioning by treating the primary diagnosis and also helping the patient and family deal with stresses and secondary impairment. So theoretically, you can say there is role of counseling principles such as problem solving, reassurance to the parents, specific education regarding the disease, also specific parenting advice, how parents want to deal with a child with special needs, and also and we can also refer parents to the support group, and also environmental intervention. This is environmental intervention here refer to whether to put the child in institutional care. And children with special needs would need interdisciplinary team intervention, such as education, psychology, motor, speech language, social and environment, and also medical. So okay, we move on to, this is more practical part in Malaysia, where the children with disability in Malaysia would receive first, there is early detection and intervention by, the first line would be Ministry of Health, because it is stated that 95% of newborns and parents are accessible through Ministry of Health. So this health monitoring program 0 to 6 years old was actually launched at 2012, where this health monitoring program actually record the development of the children and can detect any delay in their specific developmental age. And if there is children with disabilities who remain undetected, we expect them to be filtered by Ministry of Education, which by literacy and numeracy screening (LINUS), which this test is conducted for 3 years, and for those who have failed this test 3 years will be referred to Ministry to the health sector to be further evaluated by the physician. Next, the healthcare programs that is provided to children with disabilities, such as the government hospitals and health centers, which has trained occupational therapists, physiotherapists, and also social workers. And also we have a community-based rehabilitation center, which is a one-stop center that intend to provide diagnosis, rehabilitation, treatment, special education, and vocational training, which I will talk more later. And also we also have education for these children with disabilities, such as special education school, which is a specific school for the disability children. So there are about 28 primary school specific for disability children, these special needs children, uh, which categories into hearing impairment school, visually impairment school, and also learning difficulty school. So this picture here is one of the students who have visual disability, who learn visual impairment, who learn through text in speech. And next, we also have special education integrated programs, which is, I think this one we call it as kelas pendidikan khas, which is a specific class for these children with disability in the mainstream school. And the inclusive education program, which the children with disabilities is integrated into the mainstream class. Next is the community-based rehabilitation. This one, in Malay, we call it pemulihan dalam community. So those who involved with CBR, community-based rehabilitation, we have, it is stated that they will get allowance 50 ringgit per month if they join this community-based rehabilitation. And what do we do in this community-based rehabilitation? First, there is a therapy such as physiological therapy, occupational therapy, speech therapy. Next is language and social development, which we teach them to express themselves verbally through writing and inscription. And then basic daily life skill, how to take care of oneself, regular food and water intake, bathing, toilet training, grooming, wheelchair handling. Next is reading, writing, and arithmetic, the 3R. Next is recreational therapy, which explore their talents through games, making handicraft, and playing musical instrument. And also, last but not least, independent living training. So this is the community-based rehabilitation activity. Other than that, we also have a social protection program, which is a monthly cash allowance of 150 is provided by Ministry of Education to children who enroll to special education school. And also there is Taman Sinar Harapan Homes, which provide residence and care and rehabilitation for children with disability. I think this home is for those who their caretaker, the children caretaker that do not take good care of them. And also we have a protection program for them, which is the Child Act, which cover 12 categories of children in need. And this Child Act is actually for all child, but it also extended to those with these children with disability. So the children which are in need of protection, including cases of physical, social, mental, and emotional abuse, and ill treatment, neglect, and abandonment. So the Child Act will allow the authority to take the temporary custody, to remove the child to a safe place, and also place the child to a refuge and rehabilitation. I think this is my last slide. These are my references.
Okay. Any question to the presenter before I start asking question?
I have a question.
Yep.
For the community base, is it will be conducted by the healthcare or is a volunteer thing?
Presenter?
From what I know, it is a multidisciplinary approach. But it is, I think it's under Ministry of Health, more to Ministry of Health, because this is the national bodies, and we also have the NGOs that help these children with disabilities. Am I
Yes,
answering your question?
yes, very true. So basically, it is a multidisciplinary, multi-group punya effort. Like mainly, it is under Ministry of Health. Mainly, it is under Ministry of Health. Also under Kementerian Pembangunan Wanita dan Kanak-kanak (KPWKM), who is under siapa minister dia sekarang ni? I don't remember who. Used to be under the Deputy Prime Minister before lah. So under this government, I'm not quite sure who. So basically also under Kementerian Pembangunan Wanita dan Kanak-kanak, also dia ada certain jabatan yang handle all these children with special needs as well. And also we have many NGOs as well. We have certain NGOs that cater to children with autism. We have a special NGO that caters to people with visual impairment and whatnot. So these are the things. Okay, the first thing as future doctors, several things. Cuba balik tengok dekat our yang buku baby tu. Actually, if you look at the buku baby by MOH ni, dulu kita panggil red book kan. Tapi red book tu mother yang red book. Untuk children ni dia punya buku dia will be colored based on dia punya gender lah. Kan? This book is actually very good. If you look at this book and you compare with children who are born in private hospital or even children who are born in UIA, if you compare our book, those from KMC, those from Pahang Medical Center, those from, even if you compare with this book from UK, actually the KKM book is very good in terms of the robustness, in terms of the capability of record tracing and things. So this is a very good effort. Mari kita boleh, with this book kita boleh identify many things. We can identify children with developmental disability. We can identify children with failure to thrive, so growth and developmental issues. And the records are quite complete there. Banyak benda kita boleh catch daripada situ. So this is a very good effort. Second thing is something that is not covered in Afiqah punya presentation, which I don't expect to be covered. But one thing I need to remind you all, as doctors, one thing before we handle children with disabilities is actually we need to know which children risk to have disabilities, which children are at risk, which newborn, even before they are born, which cases are at risk to develop disabilities later on. For example, if you know antenatal scan kata some abnormalities, short femur length, for example, dia compare, dia buat dia punya fetal scan kan, semua everything okay except short femur length. So short femur length, you need to think, is it things like achondroplasia or something? So sometimes they may have this sort of problem. So from very early on, you identify. So this is a sort of baby that will grow up to be a child with disability. Or masa antenatal scan, dia nampak local translucency dia very high. And increased local translucency maknanya there's risk of a child having syndrome, syndrome, Down syndrome, blah semua kan. So these are sort of babies yang akan ada problem kan. So bila kita boleh identify from very early on, we may start the early intervention program very early on. Identifying the children who are at risk. For example, apa lagi? If you have a child who has severe jaundice, why do we follow up the child very frequently? Kenapa? Dia severe jaundice, requiring exchange transfusion. Kita follow up at least until 2 years old. Why? Anyone can give an idea?
Chorioadenoid CP risk.
Yes, so because they are at risk to develop coronavirus CP and everything, so we need to identify. Okay, sorry, someone is. Okay, wait. Let me change my. Hello. Okay. Clear? Okay. Is it still loud? Better. Ni ada noise lagi tak? Tak ada. Okay. So basically kita nak kena identify which children are at risk. So yang ada severe jaundice, you know, they are at risk to develop cerebral palsy. So sebab tu kita nak kena ada follow up dengan dia. For example lagi, children yang infant of diabetic mother. Apa benda yang kita nak kena watch out? Infant of diabetic mother. Kenapa kita admit those babies?
Hypoglycemia.
Yes, hypoglycemia. So what's the problem with hypoglycemia?
Indecision.
So hypoglycemia sometimes dia boleh affect your intellectual function. So children with hypoglycemia, among the complications that they may have is actually intellectual impairment, developmental disabilities and things. So you have a child who's admitted for neonatal sepsis. You start the child on antibiotic with penicillin and gentamicin. And then you monitor therapeutic drug monitoring, kan? You do TDM level of gentamicin. And then you found the gentamicin level to be very high. So this is a sort of baby that we will follow up for a very long time. Why do we follow up? And we send the child to another department for testing. Why? Anyone has any idea?
Ototoxicity of the gentamicin.
Ototoxicity, so hearing issues. So you need to send them for hearing assessment because we know gentamicin has ototoxicity. So that is why understanding which children are at risk is very important. And then we follow up them properly, and then we refer them early if we think there's any problem. If we think there is any hearing impairment, we refer them early. And then also, for example, in IIUM Medical Center, we only start, I think, we haven't actually started yet, universal hearing screening. So we haven't formally start yet. But in KKM pun dia dah start universal. So all babies are screened for hearing. So identifying risk is very important. Identifying risk is very important. Okay. And then as well, if you look at our system, KKM, I think this is why our Ministry of Health is recognized as among the top 5 health system in the world. Mainly because our connection between hospital and also community base is very good. So we have this jururawat masyarakat who goes on to do home visits at home. Our community service is very, very good. I would say the only problem that we have is we don't have enough seniors. We don't even have any community pediatrician in Malaysia. So we don't have very, very senior pediatric physiotherapists or pediatric occupational therapists. We don't have that many developmental pediatricians. So these are the things that impair us a bit. But at the ground level, we have a very robust and very good system. So kita boleh identify, kita boleh treat even at community level. But the centers are not that enough lah. Tapi maknanya ada. Cuma dia tak boleh dapat buat too regular. Tapi sistem tu sudah ada. Of course not as good as UK for example. Tapi at least the system is there. But for us, contohnya, if you guys become sebelum jadi specialist, if you're MO, selalu apa? Selalu cikgu sekolah, teachers from school, dibawa children jumpa doktor. Kenapa? Sebab cikgu kata even at 8 years old, the child is not reading well. Sometimes they detect much earlier. So dia kata, our teachers are quite good actually, they are quite trained. So dia tahu, ni macam dyslexia, So ini macam autistic spectrum. So they're going to refer to us for assessment. So usually the first line of assessment is MOs. So MOs tengok dulu and then MOs akan refer. Dia akan refer sama ada pada pediatrician or to psychiatrist lah for further assessment. So but these are the things that we will face. Okay, alright, clear. I think if there's no other question, let's go to the next presentation.
Okay, can you see my slide? Yes, yes.
Ini baru tukar atau okay. Tadi dah nampak tukar. Tak tukar pun.
Oh, tak. Okay, Assalamualaikum warahmatullahi wabarakatuh to Dr. Syed and my fellow friends. Today, I am the second presenter for today's seminar.
Hello? Is it only me that is getting it stuck or Zafirah problem?
Zafirah start.
Zafirah start, please.
Terkejut nak kena present.
I think she's having an internet problem.
Alamak. Ke sebab dia nak project dia punya screen as well ni. Mana Zafirah? Zafirah dah masuk balik belum? We lost Zafirah. Sometimes kalau you nak kena share screen and video as well, dia jadi heavy sikit.
Zafirah is currently having internet problem, doctor. She is connecting to Zoom right now.
Okay, all right. Okay, let's go with the next presentation. And I think probably someone else can share screen for Zafirah later bila dia on board. Okay, siapa yang? Okay, no, this okay. So who will be the next presenter? Let's start. Let's continue with that first, and then we'll go back to Zafirah. Who's the next presenter?
Me, doctor.
Afiqah. Yep. Let's proceed.
So, can you see my slide?
Yes.
How about my voice? Is it clear?
Yes.
Okay. So, I will continue the presentation with adolescent health problems. My name is Afieqah and Mr. Muhammad Win with my and
Now it's more clear.
Okay.
I think someone else need to portray the slides.
My voice is not clear. How about hear my voice?
Your voice okay.
Okay. I will continue. So, adolescent is between the age of 10 to 19 years old. It is a transitional stage from childhood. There are some conversations, but not so,
I think when you,
sorry.
your voice is lagging when you talking in a long sentence.
So, can someone project my slide?
The problem with online learning.
Try to project the slide, Afiqah. Wait,
Okay.
Afiqah kena unshare dulu screen tu. So online other people can share it. Problem with online learning kan. Tak apalah. It's okay. This is new. This is new. Okay, Afiqah, can start. We keep losing our presenter.
Hello.
Okay, Afiqah.
Okay.
Yes.
Okay, I will talk about adolescent health problems. So next slide. So this is my outline. First, I will talk about the introduction to adolescent and assessment, and also the health problems related to the adolescent. Okay, next slide. Okay, first we go to the introduction to the adolescent. So adolescent is between the age of 10 to 19 years old. It is a transitional stage from childhood to the adulthood. So they are no longer children, but not yet adult. It comprises of 1/5 of the world population, and in Malaysia, about 5.5 million of adolescents in Malaysia. However, in the year of 2020, the number of adolescents in Malaysia will increase to the 6 million. Okay, next slide. So, adolescent health can be defined as a state of complete physical, social, mental, and also spiritual well-being of adolescents that will enable them to live a healthy and harmonious life within a supportive environment in preparation for optimal health in adulthood. So basically, it comprises of bio, psycho, social, and spiritual model. Okay, next. So this is regarding the adolescent development period. So it can be divided into early, middle, and late adolescent. For the early adolescent, it is between the age of 10 to 14 years old. In this stage, there will be rapid changes in physical appearance and behavior. So they start to think whether am I normal or not. So they start to develop self-consciousness and need for privacy. So when we club patient at this age, we need to focus more on the physical and also psychosocial health. For the middle adolescent, it is between the age 15 to 17 years old. At this time, they will start to develop autonomy and a global sense of identity. Who am I? So during the history, we need to focus on the adolescents' interaction with the family, school, and peers. And please take note that at this point of time, they will start to have high-risk behaviors as a result of experimentation. So it is common at this point of time. For the late adolescent, it is between the age of 18 to 21 years old. They start to have individuality and planning for the future. So at this point of time, we can put a greater emphasis on the adolescent's responsibility for their health. So next. So this table, actually I already summarized it from you, so you can read later. Okay, next. Okay. This one is with regards to the interviewing in adolescent. So adolescent interview actually shift from the information gathering from the parent to the adolescent itself. So when we interview the adolescent, we need to use a non-judgmental approach and find some ground to get the adolescent talking about him or herself. So the approach is known by the acronym of HATES. Aqilah, can you okay. Actually, it is the acronym is only HEADSS, but it was subsequently expanded to HATES with double E and also triple S. Okay, so before we start the interview, we need to make sure that the parents, family members, or other adult should not present during the HATE assessment unless the adolescent specifically give permission or ask for it. This is vital because open discussion about risk-taking behavior is more likely to happen when the adolescent is alone. When we start the interview, we have to introduce ourselves first. If the parents are present before the interview, we need to always introduce ourselves to the adolescent first and then to the parents. And then we ask the adolescent to explain their understanding of confidentiality. And after the adolescent has given you his or her views, we acknowledge their response and add our views accordingly based on particular situation. So with regards to confidentiality, there are some issues that cannot be kept confidential, such as suicidal intent and also disclosure of the sexual and also physical abuse. When we want to end for interview, we need to give them an opportunity to express any concerns and ask if there is any information you can provide on the topics. Okay, next. This is the component of HATES assessment. H for home, we can ask with regards their home environment, their families, and others. For E, education, we can ask about their school, the performance, their favorite subjects, and also their peers. And E, for eating, but if the adolescent is has a job, we need to ask regarding the employment. For eating, we can ask about their body weight, about their diet history, exercise, and also any episode of binge eating or purging. For activities, we can ask regarding their peers and also the activities on weekends, sports, hobbies, And also, did they ever involved in with police or belong to a group or gang? D, for drugs, we can ask regarding alcohol, smoking, and also drug misuse. And last is not last. Okay, for S, sexuality, we can ask regarding their relationship, and also regarding the sexually transmitted infection. And also for female, we can ask about menarche, LMP, and also menstrual cycle. And not forget regarding the best self-examination practice. For men, we can ask regarding testicular self-examination practice. For another 2S, the second S is regarding suicide and also depression. So we ask regarding the symptoms of depression, such as difficulty to sleep, change in appetite, and then any hopeless or helpless feeling, and ever attempted suicide. And last, safety, we can ask about injury or abuse. Okay, next. Okay, this is the health problems in adolescent. Actually, there are many, but I group it into several classification, which are physical problems, psychiatric problems, behavioral problems, dietary, menstrual, and also sexual problems. I will not talk all, but just some of it. So move on to the physical problem first. With regards to the injury, next slide. Okay, with regards to the injury, it is said that injuries were the principal cause of death for adolescents. And the two leading causes of hospital admission in Malaysia were traffic injuries and also falls. So as you can see from the figure, it shows that the number of traffic injury recorded is twice the number of injuries due to a fall among children in Malaysia. Okay, next slide. So from the figure at the left, 12% of children suffering from MVA actually are pedestrians. The statistic of MVA involving pedestrians near the school vary by age group, and the highest is among the age group of 10 to 14 years old, followed by children who are 5 to 9 years old. This is because the children in this age group have poor ability to perceive hazards, and with their restricted ability in making safe decisions. So any countermeasures that are imposed on them will be very difficult to work effectively. So as an alternative, environmental modification and measures on other road users should be given priority. So the one that can be implied to us, we as a student who are the road users, we need to implement a safe speed limit, which is less than 30 km per hour in the residential areas. Okay, next. With regards to the infectious disease, diarrhea and lower respiratory tract infection, such as pneumonia, are estimated to be among the top 10 causes of death for adolescents in Malaysia. And vaccination against the infectious disease has received far less attention in adolescents than in children. However, actually, adolescents are also important for ensuring the completion of immunization schedule, administering booster dose, and also ensuring primary immunization. So next slide, I show you the national immunization schedule for Malaysia in adolescents. So they need to get booster for MMR, HIV, IPV, DTaC, and also primary immunization for HPV. Okay, next. With regards to the psychiatry problem, based on NHMS, it shows increasing trend in mental health morbidities among 5 to 15 years of age from 1996 to 2011. So from 10.7% to 20%. In GSHS, the Global School Health Survey showed that 7.9% students ever seriously considered attempting suicide, and 6.7% was actually attempted suicide one or more times. And based on the age groups, the psychiatric morbidity are more common among 15 to 16 years old. Next. This is the latest survey by NHMS 2019. It is found that 424,000 children were found to have mental health problems in Malaysia. And okay, next. There are two major alarming issues in psychiatric problems among adolescents, which are depression and also suicidal. So we need to improve detection and recognition of early difficulties, as well as more comprehensive early intervention problem, particularly among at high risk group. Okay. So this is high risk individual to get depression. So it can be first patient adolescent with first degree relative with history of depression, for adolescent who suffer from chronic pain or experiencing major life changes, presented with multiple vague symptoms, chronic disease such as asthma or others, impoverished home environment, or pregnant, sleep disturbance, obesity because of body shaming, financial constraint, socially isolated, and also substance abuse. So for this high-risk individual, we need to ask for screening question, which are we ask regarding the feeling of depressed or hopeless for the past 1 month, or any feeling of little interest or pleasure in doing things. So if one of these two questions, they said yes, we need to further explore regarding the depression symptoms. Next. So this, I will just want to show you the MDD symptoms. We all learn this, so I will skip this one. Okay, so investigation. After we diagnose MDD, we can do some investigation to know the severity of MDD. And during the history taking, we can ask regarding the sad person scale for the assessment of the suicide risk. We all learn this, so I will skip this one. So basically, MDD have non-pharmacological treatment and also pharmacological treatment. Okay, I will skip this one. Okay, with regards to the behavioral problems, so violence is defined as intentional use of physical force or power, threaten or actual against oneself, another person, or against a group of community that either results in or has a high likelihood of resulting injury, death, psychological harm, maldevelopment, or deprivation. So the adolescent can be the perpetrators, victims, or observers of violence, or any combination of the three roles with varying severity of impact on the individual, family, and also community. So multiple risk factors have been identified that may increase the risk of adolescents engaging in violence, including poverty, war, substance abuse, mental health disorders, and also poor family functioning. So this table is regarding the disorders associated with violent behaviors, which are ODD and also conduct disorder. So the difference between ODD and conduct disorder is ODD, they do not violate the basic right of others, but conduct disorder, usually they violates the basic right of others, such as they involve in destruction of the property, causing physical harm to people or animals, or prostitution. So these two type of disorders will increase the adolescent vulnerability for juvenile delinquency. Okay, next. So this picture is the assessment of adolescent at risk or with history of violent behavior, and it can be done by fifth mnemonic. So F for fighting, we can ask regarding how many fights were you in last year, and what was the last fight. And then I, regarding the injury, have you ever been injured, or have you ever injured someone else? S, regarding the sex, we can ask their sexual history or any history of rape or others. And then T, regarding the traits, has someone with a weapon threaten you, or with regards to the self-defense, what do you do if someone tries to pick a fight? So this assessment is done for adolescent with history of violent behavior or at risk at violence. So in people with adolescent with violence, we can, the treatment modalities that we can offer is CBT, family intervention, such as parents management training, because usually adolescents that involved in violence, they have dysfunctional family. So we need to treat their family also. And then we can offer pharmacotherapy and treat existing comorbid condition, because sometimes the violence is also comorbid with other psychiatric morbidities such as ADHD. So we need to also treat ADHD. Okay. Okay, next with regard to the substance abuse. So this survey is taken from NHMS 2017. So with regards to the smoking, about 10% of Malaysian adolescents smoke, and it is more among boys, which is 22% compared to girls at 5%. And the prevalence of current cigarette smoking by ethnic was highest in Bumiputra, Sarawak and Sabah. Okay. And 16 Form 4 students reported the highest prevalence of current cigarette smoking at 15.3%. With regards to the alcohol, about 10% of Malaysian adolescents were current drinkers, and 76% of them sip their first alcoholic beverage before turning 40. So this is actually illegal, because the legal drinking age in Malaysia is 21. And it is sad because the most common source of obtaining alcohol among them is from the family, which is 38%. And then with regards to the substance abuse, it is less than 5% adolescent were current drug users, and 17% of them initiated the drug use at age 7 years or younger. So it is a sad fact in Malaysia. So with regards to the substance abuse, it can be tobacco, alcohol, and also drugs. Next slide. Next slide. Okay. So there are multiple risk factors regarding the substance abuse, such as psychiatric problems, low self-esteem, low school achievement, dysfunctional family, or disconnectedness from the school, difficulty talking with parents, and also availability of the substance, and also the peer influence. So the protective factors are family connectedness, perceived healthiness, and also religious affiliation. So during history taking, we need to ask regarding the risk factors and also protective factors. Next. So substance use in adolescent is actually associated with multiple problems, and it can increase the acts of juvenile delinquency. So the adolescent may engage in other high-risk behaviors such as robbery, drug dealing, or prostitution for the purpose of acquiring the money necessary to buy drugs or alcohol. So regular use of any drug eventually will diminish the judgment and is always associated with unprotected sexual activity with its consequences of pregnancy and STI, including HIV, as well as physical violence and trauma. And any use of injected substance involving will involve the risk of hepatitis B and hepatitis C as well as HIV. So when we want to approach adolescent who had violent behavior or involved in substance use, so we need to ensure the confidentiality, explain our role and intention, and before we ask further, we need to build a good rapport first. And please do not be judgmental, and chase the parents out first if necessary, and please do not be rush. And if adolescent wants the doctor to be the same gender, so we need to be the same gender with them lah. And if the adolescent shy, we can ask them to write down. Okay. Next. So the craft mnemonic is specifically designed to screen for adolescent substance use in the primary care setting. So craft, C stand for the car. So we ask them, have you ever ridden in a car driven by someone, including yourself, who was high or had been using alcohol or drugs? And then R for relax. Do you ever use alcohol or drugs to relax, feel better about yourself, or fit in? And A alone, we ask, do you ever use alcohol or drugs while you are by yourself, alone? F, forgetting. Do you ever forget things you did while using alcohol or drugs? And then, do your family or friends ever tell you that you would cut down on your drinking or drug use? And last, we ask, have you ever gotten into trouble while you were using alcohol or drugs? So this screening tool was done in primary care setting. However, if the adolescent presented to emergency setting with an impaired sensorium, we need to evaluate for substance use. So we will not do the screening tool. We will just order for urine toxicology. Okay. I think this one no need code. No need. Okay. So this M5 substance use disorder, we all learn regarding this one. So I will skip this. Okay. For the adolescent drug abuse, it is basically a complex condition. So it requires multidisciplinary approach. So we can use trans-theoretical model with each the stage of change. This model will enhance the motivation for change in substance abuse treatment. So first is the pre-contemplation. So in the pre-contemplation phase, the adolescent will not yet considering change or is unwilling or unable to change. So our primary task is raising awareness. We raise their doubt and increase the patient's perception of the risk and problems with current behaviors. For the contemplation phase, it is when the patient sees the possibility of change but is ambivalent and uncertain. So our primary task is to resolving the ambivalence and helping the patient to change by evoke reasons for change, risk of not changing, and also strengthen patient's self-efficacy for behavior change. And then for the preparation, okay. For the preparation, it is when the patient committed to changing and still considering what to do. So we need to help the patient determine the best course of action to take in seeking the change and develop a plan. And then action, it is when the patient taking steps toward change but has not stabilized in the process. So we help the patient implement the plan, use the skill and support the self-efficacy, and then maintenance, which is keep going when the patient has achieved the goals and is working to maintain the change. So our primary task is helping the patient identify and use strategies to prevent relapse. And sometimes the patient can have relapse. So we can help the patient recycle through the stage and without becoming stuck or demoralized because of the relapse. Okay. So this one we learn in family apa? During year 4. Okay. So basically, okay, I just want to remind you again regarding the 5 A's to quit tobacco and also 5 R's to the patient unwilling to quit tobacco. So you can read it later. Okay, next. With regards to the dietary problem in adolescent, so basically the common dietary problem in adolescent is anorexia nervosa and also bulimia nervosa. Okay, next. You can read this one letter.
Afiqah, go back to the smoke.
Okay.
Okay, my question is, do you treat vaping as the same?
Yes.
Why?
Because vaping also can increase risk. Vaping also associated with multiple problems.
Why is vaping a problem? What is the problem with vape?
It can damage the lung.
Okay, anyone else has any other idea or suggestion?
Nicotine.
Huh? What else? What? Someone was trying to say something just now?
If I'm not mistaken, the nicotine in vape is higher than in tobacco.
Okay, so the issue, okay, vape ni apa? What is vape?
E-cigarette.
Okay, so vape, e-cigarette, if you see actually, it is almost the same. Cuma in Malaysia, we classify them as two different things. E-cigarette and vape, we classify them as two different things. So e-cigarette is where we have the where we have the nicotine in it. Okay, so basically, if you look at government punya law in Malaysia as compared to other countries, is very different lah. Especially in countries like UK. If you look at UK, their smoking incidence is very high. Their population that smoke cigarette is very, very high. In Malaysia, we see smoking is seen as dirty, something that is orang tak suka. Orang, you smoke outside ni orang tak suka, orang frown upon, something that is frowned upon, smoking. Kan, bau busuk, orang nampak ni orang-orang kasar kalau isap rokok kan. Kalau doktor yang isap rokok pun dia sembunyi, dia tak open kan. But in countries like UK, this is very common, very, very common. Even pregnant ladies pun selamba je isap rokok dan sebagainya. So it is very common. So they did, if you look at Public Health England punya website, for example, they are still promoting e-cigarette as a measure to reduce basically for smoking cessation, because e-cigarette obviously has lower risk for almost all the problem that smoking has. Okay, the problem with Malaysia, satunya kita nampak few things. Okay, satu, dengan vaping ni lebih kurang sama dengan shisha. Maknanya dia convert daripada fluid yang ada flavor dalam tu, yang ada nikotin, ada caffeine dalam tu, dia convert into vapor. So that is vaping. Dia convert dia daripada liquid kepada vapor. That is vaping. Macam shisha, macam apa. Shisha ni, if you look at history, if you look at Islamic history, shisha ni used to kalau tengok siapa biasa baca pasal Hasan al-Banna dan Ikhwanul Muslimin, for example, Hasan al-Banna pernah mention benda ni. Sebab shisha ni they used to put marijuana. One of cara dia hisap ganja is by shisha, hashish. Kan hashish ni memang marijuana lah. So memang dia guna ganja dalam tu untuk dia get high and things. So that's the same problem dengan vaping ni. The issue is to make the flavor is very easy. Dia boleh buat dekat rumah sahaja. Dia just nak kena ada dia punya e-cigarette punya stick tu, vaping punya machine tu, and then dia punya flavor tu boleh buat sendiri, concoct at home by yourself. Dia boleh buat sendiri. So itu yang satu tu lah. The issue is it's so easy for people to put other substance in it, ganja ke whatever illegal substance ni dia boleh masuk dalam tu untuk get them high easily, and then it will be very difficult for us to control. So kalau boleh buat kat rumah, bancuh dalam botol-botol biasa semua kan, mana nak tahu ini heroin ke apa benda, ganja ke apa kan. So it's very difficult. Itu satu. Yang keduanya, so kalau dia totally betul-betul untuk smoking cessation, then it is okay, we can understand, we can accept. Tapi the problem sebab dengan e-cigarette atau vaping ni, dia tak ada this pungent smell daripada smoke, tak ada bau asap busuk tu kan. Kadang bau dia fruity, dia boleh keluar bau fruity daripada vape kan. Lepas tu gigi tak jadi rosak, mulut bibir tak jadi rosak. So people nampak dia macam okay. So instead of the smoking cessation, what happens dengan vaping or e-cigarette ni, people yang tak pernah smoke, dia start smoking sebab setiap kali dia smoke tu dia ada fruity smell, dia ada bau macam-macam. Kan dia boleh letak bau, certain fragrance pun boleh keluar. So it makes the smell tu menyebabkan people yang tak pernah smoking start vaping. Lepas tu children pun sama. Children pun sebab nak hisap rokok is quite difficult, dia kena ada teknik dia kan. Tapi dengan vaping, e-cigarette ni is much more easier. So even children starts to vape. So this is the problem that we have identified in Malaysia. So that is why we regulate this thing. This is why we regulate this thing. Okay, alright, proceed.
Okay. So move on to the dietary problems. So the most common is anorexia nervosa and also bulimia nervosa. So it is commonest in mid-teens and more common in female, where the female to male ratio for anorexia nervosa is 20:1 and the female to male ratio for bulimia is 10:1. Okay. And this dietary problem also associated with depression, social phobia, panic disorder, GAD, and also OCD. So the difference between anorexia nervosa and also bulimia nervosa is in anorexia nervosa, it mainly refers to starving and create a skeletal-like body. But bulimia nervosa, they usually have episodes of binge eating followed by purging. With regards to the body weight, usually anorexia nervosa will have a very thin and low BMI. And for bulimia, they usually have average weight, ideal for their height and age. And with regards to dietary habits, usually anorexia nervosa will reduce their calorie intake and tend to eat less, but bulimia nervosa, they cannot control their appetite, so they usually have heavy meals followed by purging, and the complication in anorexia nervosa usually associated with amenorrhea, osteoporosis, and infertility. But in bulimia, because of the purging, so it can result in damage to the esophagus and teeth. Okay, next. So this complication of eating disorder, but I think you can read this later. Okay, so basically for the general management of anorexia nervosa and also bulimia, first we need to restore the function. So we need to restore the patient's nutritional state. when the patient had dehydration, starvation, or electrolyte imbalance. Then we need to identify this patient whether they need to hospitalize or not. So it is based on the patient's medical condition and the amount of structure needed to ensure the patient's cooperations. And then we can give psychoeducation regarding the disease, the effect of the nutritional problems, and teach nutrition a healthy diet. And then we can also offer psychotherapy such as CBT, dynamic psychotherapy, and also family therapy, because sometimes this disorder usually associated, usually it is family. Basically, we can give family therapy because this disorder can this disorder can also happens in it is can be genetic, so they can have similar problems.
Basically there's a family preponderance, and also sometimes it runs in the family, isn't it?
Runs in the family. Okay. And last but not least, we can offer antidepressant, especially in bulimia, because they often have personality disturbance, impulse control difficulties, and family history of affective disorders. So such as fluoxetine, which is SSRI. Okay. Next, with regards to the obesity, so it is one of the major burden faced by the new generation of adolescents. In the new survey, the NHMS 2019, it is said that 29.8% of children below 18 years old are found to be overweight and obese. So it is actually a problem, and we can cater this problem by changing their secondary lifestyle, advise them to decrease consumption of calorie-dense food, and also increase outdoor activity. And then the table below, I just want to show you the weight status category. Okay. Next, these are the complications of obesity. So basically, there are many. For example, they can cause OSA, metabolic syndrome such as hypertension, ischemic heart disease, diabetes, PCOS, and others. Okay. With regards to the menstrual problem, so basically menstrual disturbance occur in 75% of females during adolescence, and menarche typically occurs approximately 2 years after the onset of second breast development, and at the average of 12.6 years old. With regards to the irregular menses, it is common during the first 2 to 5 years after menarche, because the initial menses are involuntary and tend to be irregular in duration. So, we need to explain of the symptom and reassurance only. So, with regard to dysmenorrhea, it is the most common gynecologic complaint of adolescent, which is painful menstruation during the first 1 to 3 days of bleeding. So it can be primary or secondary. For the primary dysmenorrhea, is defined as pelvic pain during menstruation in the absence of pelvic pathology, and it is because of a feature of ovulation, and it usually developing 1 to 3 years after menarche as a ovulatory cycle established. For the secondary dysmenorrhea, is defined as pain associated with pelvic pathology. Okay. And most frequently caused by endometriosis or PID. So, for the treatment of dysmenorrhea, the first line is NSAIDs. Okay. Next. Regarding the sexual problem, okay, based on this survey, NHMS 2017 pregnancy, there are 7.3% of 13 to 17 years old adolescent had already had sex. And 35% of male and 70%, 35% of male ever had sex before age 14 years old, and 27% of female had sex before the age of 14 years old. Okay. Can you click, Aqilah? Okay. So from this figure, actually pregnancy should be considered and to rule out in any adolescent presenting with secondary amenorrhea. So we need to have a thorough menstrual history, and they can present with multiple problems. In early adolescence, they often present with other symptoms such as vomiting, weight pains, and also deteriorating behavior. And they may also report normal periods. But in frequently pregnant adolescent, usually they can delay seeking a diagnosis until several periods have been missed, and they can deny having intercourse. So we need to have a thorough menstrual history lah. And then we can, if we suspect pregnant, so we can do UPT, and the UPT result can be positive 7 to 10 days after the conception, even before the patient had missed menses. And then we need to also rule out for rape in all cases of adolescent pregnancy. Okay, next. With regards to the rape, it is basically defined as physically forced or otherwise coercive penetration, even if slight of the vulva or anus using a penis, other body parts, or an object. So it is a legal term for non-consensual intercourse. So almost half of the rape victims are adolescents. Near 2,000 cases of rapes in 2017 are reported in Malaysia. And the statutory rape, the Penal Code 574 states that a man is said to commit rape if he has sexual intercourse with a woman with or without her consent when she is under 16 years old. Okay. So for the acute management of rape, first is the history taking. We need to take a complete history, which includes the detail of the sexual assault, time from the assault until the presentation, whether the victim cleaned herself, and date of LMP, and also other previous sexual activity, if any. For the forensic material, so for optimal result, the forensic material should be collected within 72 hours of assault, and the clothes, especially undergarments, need to be placed in a paper bag for drying, and the patient should be inspected for bruising, bites, oral, genital, and anal trauma. The photographs are the best record to document the injuries. And we can also do culture for STI, but usually they are often negative. And then for the examination, detailed examination should be done by the appropriate respective departments. So from the OSCC, One Stop Crisis Center Policy and Guideline for Hospital in Malaysia, it is said that for all alleged rape and sexual assault survivors, shall be referred, managed, and followed up by the attending specialist from ONG department. And in the case of child abuse or neglect cases, it should be managed by the pediatric department or SCAN team, the suspected child abuse and neglect team. And all sodomy survivors, which is sodomy means anal intercourse, shall be referred to the surgical departments. And then for the therapy after a rape includes prophylaxis for emergency contraception and STI. Okay, next. So this is the three types of emergency contraception available in Malaysia. The first one is levonorgestrel. It is progestogen. It can be obtained over the counter and it can be used up to 72 hours of unprotected sex. For ulipristal acetate, or the brand name is usually Ella, it can be used up to 5 days post unprotected sex. And for the copper IUD, it is more effective and can be used up to 5 days post unprotected sex. Okay. So for the prophylaxis treatment for rape victim with regards to the STI, so a single dose of ceftriaxone and azithromycin can treat Neisseria, chlamydia, and also syphilis. And for prophylaxis against bacterial vaginosis and trichomonas, we can give a single dose of metronidazole. Okay, and the culture need to repeat, and the UPT need to repeat 3 weeks after the assault. And it followed by the serology for syphilis, hepatitis, and HIV at 12 weeks. Okay, next. Okay, so why we need to do health promotion in adolescent? This is the reasons. So the first one is it is a period for starting health risk behaviors. And the second reason is because the health risk behaviors started in adolescent often continue in adult life, and the health behaviors may have direct effect on their life, such as teenage pregnancy, suicide, and last but not least, it can increase the morbidity, such as obesity and also metabolic syndrome. So I think that's all from me. Okay. Any question?
Any question from the group? Adolescent medicine is something that is, if you ask me, is something that is very difficult. Why is it difficult? Because in adolescent, they have their own they have their own complexity as the years goes by, kan? 5 to 7 and then 7 to 10, 10 to 14, dia punya the difference in terms of, and 14 to 17 to 19 and whatnot. The stages of how their mind develop and things. Okay, for example, in a child with diabetes, for example, the moment they go into adolescent period, usually this is where the problem comes with compliance issues and things. Childhood obesity is another issue yang kita nak kena settle, and I think not that much effort lagi yang ada buat di peringkat adolescent. So in Malaysia, we don't have that many adolescent pediatrician. Adolescent pediatrician ni, kita I think less than 5 in the whole of Malaysia. Less than 5. So macam mana kita nak ada robust program untuk adolescent kalau we don't have enough number? For example, you all semua pergi sekolah dulu kan? Anyone dekat sekolah dia yang ada offer good healthy food dekat sekolah? Tak ada kan? Semua makan macam haram kan? Harga kantin, harga Yahudi punya harga. Tapi makan apa-apa je kan? Dengan air yang very unhealthy, air nasi lemak kosong dengan sambal ikan bilis pun mungkin seekor je ada dalam tu kan? Semua very very unhealthy food kan? Harga mahal, tapi very very unhealthy. So macam mana kita boleh nak plan? Sebab these are adolescent issues kan, maknanya children and also adolescent. Dekat tadika, alhamdulillah tadika nursery dia punya food, apa yang dia dapat is very good, actually even better than home. Nursery tadika, kalau kita tengok dia punya food yang dia prepare is very good, I've seen, it's very good. Tapi the moment dia masuk primary school, the moment dia pergi ke secondary school, terus in terms of nutrition yang dia dapat is very bad. It's very bad kan. So and then sama pula dengan kalau kita kata sekolah ada prepare things untuk physical activities, co-curricular activities untuk reduce obesity and things. The problem with Malaysia macam mana? The problem is orang yang sportsman, yang involved in sports, orang tu je semua sport dia main. Orang yang tak biasa main sport ni, dia neglected lah. Cikgu pun tak nampak dia kan. So dia ada preference apa semua. Sebab sometimes setiap sekolah dia nak siapa jadi champion dan sebagainya. Dia compare in terms of that. So the purpose is to be the champion. Bukan the purpose is to help health of the children. So ni among the issues yang saya rasa kita kena settle. It's a good thing kalau you all boleh come up with a suggestion. Macam mana nak buat, for example, as year 5 batch, buat satu plan program untuk kita masuk sekolah, for example. Macam mana idea kita nak ni, kan? So I think so many issues with adolescent health yang still needs rectifying. So many. There's so many. Okay. Alright, let's go to the next presentation. Sekarang dah pukul 10:20 dah. Okay, let's go to the next.
Okay, Assalamualaikum, Doctor. So I'm sorry before for the disturbance. Anissa. Anissa share screen Kejap.
Zaf share ke?
Ada.
Okay, Assalamualaikum warahmatullahi wabarakatuh. To my fellow friends, I'm sorry before for disturbance before. So So today my topic is mental retardation. So actually mental retardation was not used anymore today because it is very stigmatizing and not nice to hear. And then we use intellectual disability instead. Kenapa? Sekarang.
Start ke apa?
Okay, so we use intellectual disability instead. So I'll talk on the intellectual disability because most of sources is actually called intellectual disability. So this is my outline of presentation, which consists of definition, classification, etiology, clinical manifestation, investigation, and management. So the definition, I took the definition from the National Textbook and UpToDate.com. So from the National Textbook, so the definition is a group of disorders that have in common deficits of adaptive and intellectual function. And age of onset is before maturity is reached. So from the lesson it says that there are 3 criteria that must be met, which are first, significantly impairments in intellectual function, which refers to the performance of individual that administer from the test. So that is a test that can measure the intellectual function, which we usually heard is IQ, right? So if there is significant impairment, the IQ is 2 standard deviation below the mean of the test. For example, if a test that is a mean of hundreds and standard deviation is about 15, so any scores, IQ scores that below 70 would meet this criteria of impairments of intellectual function. Next is significant impairments in adaptive function. It reflects the degree that impairs the daily function. So adaptive function is about the skills that are required for people to function in their everyday life. So it consists of 3 skills, which are conceptual, social, and practical skills. And I will explain later. And Nelson mentioned that Nelson and UpToDate.com mentioned that the criteria is for the criteria of adaptive function it must have at least, it must have at least one delays in either conceptual, practical, or social. So we can consider there is impairments in adaptive function, at least one lah, either one. And then the last one is onset is before 18 years old adulthood. The onset of the symptoms that we observe there is impairment is before 18 years old lah. And then this is up to date. So the up to date punya definition is actually the same as Nelson. There is difference in terms of sentence lah. It is the neurodevelopmental disorder that begins in childhood and characterized by limitation of intelligence and adaptive skills. At least one of three adaptive domains, which I mentioned before: conceptual, social, and practical. And then it's basically the same lah. So what is adaptive functioning? What I have mentioned about conceptual, social, and practical. So from the conceptual skills, it is about literacy, like language, reading and writing, and then mathematics, money, time and number concepts, and theoretical or abstract such as reasoning, memory, self-direction, and judgment. And then for social skills, it's about the social communication, empathy, ability to friends with ability to be friends, and then social problem skills, social problem solving, social responsibility, and self-esteem. And also in social skill also included the gullibility, the ability to follow rules and avoiding victimization. So if macam about so next is practical skills, which most part covered about the daily living skills and some additional skill. Daily living skill is about eating, dressing, mobility, and toileting. And then additional skills like following a schedule or routine, using a telephone, managing money, preparing meals, occupational skills, and ability in transportation, healthcare, and safety. So actually, the adaptive functioning is also being tested by some kind of standardized test to assess these particular domains lah. And then I will talk later. So this is the test, a review of the test of according to the intellectual or adaptive test, and according to the age, what test we need to use for corresponding to the age. However, I will simplify it. So the first one is Bailey scales of infant development. It is most commonly used for intelligence scale in infant. So it assesses language, visual problem skills, behavior, fine motor skills, and gross motor. And this Bailey scales of infant development is for infants until up to 42 months old, about 3 years, of age. And then next one is Wechsler scale. So Wechsler scale have been divided into Wechsler preschool and primary scale of intelligence, and Wechsler intelligence scale for children. First edition. So for the first one is for mental for age about 3 to 6 years old, and then the Wechsler intelligence scale for children is for above 6 years of age. And then the next one, to test the adaptive function, we use Vineland Adaptive Behavior Scale or VABS. This involve interviews with the parents and or caregivers or teachers that assess adaptive behavior in 4 domains, either communication, daily living skills, socialization, and motor skills. So next we move on to the classification. So the classification of intellectual disability being divided into mild, moderate, severe, and profound. So it is there is corresponding IQ level of this severity level. So for the mild and for the mild ID, so it is between 50 to 70, and then the adaptive functioning that have impact is conceptual require academic support, social, have immature social skills and personal judgment. And however, practical is mostly independent. So the MAR-ID children can able to do activity daily life. For moderate, this IQ is between 40 to 50. The conceptual skills only learn up till elementary level, the primary level, and then social regularly need support, and then the children have independent self-care with moderate support. And then for the next is severe, it is between 20 to 40. Yeah, they are like little understanding of written language or number, time, and money concepts. And they may use very basic single words, phrase, or gestures. And individuals are trainable in some basic action in daily life for practical skills. And then proportion is less than 20. It is very disability like in intellectual. So macam may use objects into directed session for self-care, can express non-verbally, and very dependent for the activity of activities of daily living like toileting, eating, showering. This classification is I go from DSM-5 and up to date. However, in Adolescent, it only classified into mild and severe. So the IQ for mild is 50 to 70. However, in severe, it considers severe if IQ is less than 50. It is in Adolescent. And then next we move on to the etiology. So the etiology have been divided into genetic causes and environmental causes. So for the genetic causes, have been further divided into chromosomal disorder or single gene disorder. So for the chromosomal disorder, it involves like Down syndrome, which is trisomy 21, and the rest is actually is a mutation or deletion of the chromosome itself, such as the Josh, William, Benjamin, Prader Willi, Smith Manganese, and Kudachin syndrome. I will explain later on. And then next is single gene disorder. For example, is inborn error of metabolism, and the most common is phenylketonuria. And then Fragile X syndrome and Rett syndrome is X-linked disorder. That's for genetic causes for intellectual disability. And then next one is environmental causes. First, environmental causes can be divided further into antenatal or intrapartum and postnatal. So for the antenatal, it has intrauterine infection, such as TOSH, which is Toxoplasma, Rubella, cytomegalovirus, and herpes simplex, and others such as syphilis, hepatitis B, and varicella zoster. And then next is drug injection during pregnancy, such as phenytoin, alcohol, and mercury. And then any cerebral malformation such as hydranencephaly. And last one is radiation, any exposure to radiation such as lead exposure. And then intrapartum is there any preterm birth or prematurity, infection, hypoxia, intracranial hemorrhage, or trauma. And then postnatal. Yes.
Zafirah, ada siapa orang Kelantan tak dalam ni? Siapa orang Kelantan dalam ni? Dalam grup, your group. Ada Kelantan?
Saya doktor.
Pernah dengar sare? Pernah dengar? Sare? Ha?
Untuk
Makanan yang dipanggil sare. Biasa dengar?
ada sarang terbuatnya ada.
Bukan sarang terbuat.
Bukan.
Sohi
makanan.
Kelantan juga.
Miso.
Sohi.
Pernah dengar?
Tak sure,
Pernah dengar?
tak
Sare?
Sabu.
Ha?
Sabu sare.
Bukan. Sare. Sare ni I'm not quite sure kat sare ni dia macam mana dia buat lah. Tapi if you look at, I think it was it 6 years ago, Ministry of Health keluar satu guideline. Dia tak bagi sare ni tak boleh makan dah, because the idea is sare ni dia dapat daripada, it got from something from sea. So dia ada high mercury content. So dia ada high mercury content, and mercury, as mentioned here by Zafirah ni, the problem is it can affect intellectual lah. So this is for example one sort of food yang mungkin kalau Kelantan ni tanya, you go and ask your elderly parents ke ni, biasa sare ni apa dia sare ni. So dulu ramai orang makan, tapi now they didn't allow. I think it was 6 years ago lah. Ada keluar satu guideline because it has high mercury content. Okay, itu je nak cakap.
Doktor, tak sama dengan kabu saya. Kabu.
Rasanya macam tu dia makan dia makan macam kabu apa semua benda tu.
Dia macam, tapi ada lagi sekarang doktor.
I don't know lah, itulah, tapi because dia bukanlah dia diharamkan. So the issue is dia bagi advice, isunya sarai tu dia has high mercury content. So dia boleh affect benda macam ni lah, intellectual ni. So lah makan sarai tu dah.
Okay, thank you doktor.
Okay, so next, I will continue to next, which environmental causes is postnatal, so such as accidental or non-accidental injury, CNS hemorrhage, CNS malignancy, in structural disorder like tuberous sclerosis, and then intracranial infection, hypoxia, such as in near drowning, environmental toxin like lead before, and then metabolic or endocrine such as hypoglycemia, hypothyroidism, and then malnutrition and psychosocial deprivation or neurodevelopmental disorder or mental health problems such as ADHD, attention deficit disorder, and autism spectrum disorder, and mental health problems such as depression, anxiety. Okay, next I explain a little bit regarding the syndromes. So for the first one is Down syndromes. It is trisomy 21, and it is the most common genetic cause of intellectual disability. So basically, Down syndrome is characterized by dysmorphic features like in the pictures, and then congenital malformations and other health problems as medical conditions. So for Down syndrome children, they are mostly mild to moderate intellectual disability with intelligence is between 70 to 30. And however, some of them having a severe one is between less than 20, IQ is less than 20. And then the next one is Credit syndrome. It is under deletion syndrome. Occurs at the short arm of chromosome 5. How it is Credit syndrome, like the names cry. So there is a cry-like, cat-like cry in infancy with growth failure, microcephaly, facial abnormalities, and mental retardation. So these some features of Credit syndromes. And then the next one is Rehabilitation syndromes. Kejap doktor. Sorry. Okay, so next for Rehabilitation syndrome. So Rehabilitation syndrome, it is a deletion of chromosome 22, and it is by there's another name is a CASH22, which C is cardiac abnormality, A abnormal facies, timing hyperplasia, cleft palate, and hypocalcemia. So actually for Rehabilitation syndromes, it is most of in the baby, so there is a developmental delay it can occur, so later will become progress until it goes to intellectually disabled. And then next is Williams syndrome. So Williams syndrome also a deletion of chromosome 7. And then the intellectual disability is common also in Williams syndromes, but to mild to moderate range. So, however, for Williams syndrome, there is saying that they tend to be very social and friendly. For social interaction is okay. However, for other parts, maybe some deficit. And then next is Smith-Manganese. Smith is deletion of chromosome 17. And then it is mild to moderate intellectual disability. Can occur in the Smith-Magenis syndromes. And then the features is in this picture. So, and then okay, next is Angelman and Prader-Willi. Basically, Angelman and Prader-Willi, there is deletion. However, this basically the same. The mutation is at the same chromosome. However, it derived from different origin. For Angelman syndrome, it derived from the maternal origin. For Prader-Willi, it's derived from the paternal origin. So for the Angelman syndrome, it is neurodevelopmental disorder that characterized by severe intellectual disability and movement or balance disorder. And then, however, the behavior characteristic is frequent laughter or smiling, and is very excited. And for Prader-Willi, it is characterized by hypotonia. In this picture, it is mentioned that hypotonia, genital hypoplasia, small hands and feet, and abnormal faces features abnormally. However, between Angelman and Prader-Willi, Angelman is severe ID. However, Prader-Willi may have mild ID. Usually occurs in 2/3 of cases, most common. And then this is for the chromosome disorder. Next is single gene disorder. So single gene disorder, there is Fragile X syndromes and Rett syndromes. Which is Fragile X syndromes, this mutation in the Fragile X mental retardation protein. So there is the features most common in Fragile X syndrome is intellectual disability, delay in developmental delay, and learning disability. So more common in boys compared to girls. However, both can. And then for Fragile X syndromes, what I read is the boys have more severe ID compared to girls. And then for next is Rett syndrome. This is mutation in gene that occurs most aggressively in females. So usually Rett syndrome is occur in females. And then it is like in the picture, there is problems in it's having problems in development, as well as there is usually seizures are common in the Rett syndrome, so can impact the brain function. And then the next for secondary disorder is phenylketonuria, which is toxic. There is a lot excessive phenylalanine due to inability of body to convert phenylalanine into tyrosine. So the excessive amount of phenylalanine can interfere the brain growth, myelination, and neurotransmitter synthesis. So that's why it can impact the intellectual function. Next is tuberous sclerosis. Tuberous sclerosis is a mutation in the TSC gene, and then this the pictures shows most of the major features of the tuberous sclerosis. So one effect is a GA or subepidermal nodule. So that's also can impact the function of the brain, so can cause intellectual disability. And the last one is hydranencephaly, which fluid-filled cavities replace the cerebral hemisphere, cerebellum and midbrain and cerebellum, and the only preserved one is the basal ganglia. So it also have intellectual disabilities. So these are the causes from the Nielsen. The previous one is from the up to date is more in up to date lah. Next, I move on to the clinical manifestation. So clinical manifestation, so it is according to age. newborn. So what we concern on is dysmorphic syndromes and dysmorphic features such as like Down syndromes, I have mentioned before, and then multiple congenital anomalies, microcephaly, and major organ system dysfunction. And then for early infancy, like 2 to 4 months old, there are failure to interact with the environment, and then we concern on the vision and hearing impairments. And then later infancy is between 6 to 18 months old. Uh, we can see there is a gross motor delay, especially in sitting, crawling, and walking. Like, and then next is toddlers between 2 to 3 years old is having language delays or difficulties or any behavioral problems such as misconduct. And then preschool is 3 to 5 years old. Any having the language difficulties or delays, behavior difficulties, and delay in fine motor skills such as cutting, colouring, and drawing. School age, about more than 5 years old, is having there is academic underachievement. So the parents concerned about that, and then the behavior difficulties such as attention, anxiety, mood, and conduct behavior. So what we want to know, what we like to ask. So first, history. So generally we ask about the gender, either male or female, because some of the syndromes is more common in females and others like Rett syndromes. And then the second one is developmental milestones. So we ask about how the progress of development of the children, either delayed or according to the age. And then level of functioning, especially for the children, especially for all the children, they can tolerating or they can eat by themselves or not. And then next is prenatal or antenatal. Next is antenatal history. So is there any maternal infection like torch, and then alcohol ingestion during the pregnancy, smoking during pregnancy, medication use during pregnancy, or any radiation exposure like lead exposure. And then in intrapartum, how the children have been delivered. Is it prematurity or small gestational age, any hypoxia, or any congenital anomalies occurs during perinatal. The next one is postnatal, such as deep jaundice in neonatal period, convulsion and motor belly, like as we mentioned by previous presentation, deep jaundice. So next is nutritional history is of the children having a good nutrition or not. Is there any failure to thrive, physical growth, any failure to thrive, and then how the children is. Is it independent or not? And then past medical history, such as history of CNS infection, because frequent seizures also can cause intellectual disability. And then next is family history, which any family history of consanguinity, family history of intellectual disability, or family had any special education, or family had died at young age, or family history of any syndromes, like some Down syndromes, Rett syndromes. And then social history. So we need to know the social support is the parents is okay with the children, the condition of the children, and any financial support, any financial problems. So it helps in management later lah. And then any mental health problem especially for children, like preschool, is the intellectual disability can cause the children to be depression or anxiety with themselves. And next we move on to the physical examination. So what we can look from the physical examination. So from the general examination, we look for these dysmorphic features according to syndromes earlier. And then we look on the weight, height, and syndrome-specific growth charts, malnutrition, malnutrition or short or tall stature, and then head circumference is microcephaly or microcephaly, and then neurological examination, hypotonia or hypertonia, eye examination, cataract, metrobella, hypothyroidism, prominent eye, such as in fragile eye syndromes. And then ENT assessment to know the hearing impairment, because hearing impairment also can cause speech delay, and we confuse is it intellectual disability or any some impairment in hearing. And then we look on the skin. So skin, we look for tuberous sclerosis lesions such as Ashley spots, fibroma, and I've mentioned in the picture before. And then rash, such as in PKU and OCNS infection, and then bruises from the non-incidental injury, because child abuse also can cause intellectual disability. And then next we assess the heart, the lungs, the abdomen, the GU system and musculoskeletal system, because some of it is associated with syndromes. And then we assess the developmental milestone according to gross motor, fine motor, language, and social interactions. So next for investigation of mental retardation, basically the investigation of mental retardation is most of we want to detect any syndromes and also any abnormalities in the brain. So the goals of evaluation to identify a particular disorder in order to allow the clinician to provide more information to the family, so we can help in any associated prognosis, comorbidities, anticipation of future needs, and availability of any specific treatment later. And it consists of genetic studies, which consists of chromosomal testing, character analysis, metabolic studies, neuroimaging, and the EEG also can be done if there is epilepsy or epileptic syndrome suspected. So, so next. So investigation is genetic study. Genetic studies. So indication for to do genetic studies is if there is any family history of consanguinity, family history of ID, congenital visceral anomalies, history of multiple miscarriage, or family history of infant death, dysmorphic features, failure to thrive, or sexual abnormality or abnormal tone. So what we can do is like chromosomal microanalysis, which is about to detect any deletion or any duplication of the chromosomal segments. And Nelson and UpToDate mentioned that this preferred over the karyotype analysis or FISH or fluorescent in situ hybridization, especially for children with multiple anomalies or a positive family history. And then actually, many said that it is chromosomal microassay analysis is a first-line genetic test, especially for unexplained ID. And the next one is karyotype analysis. We usually do for, especially for Down syndromes, NFID and polyploidy. And any if there is concern for balance translocation, or any if the CMA is unavailable. Next is metabolic studies. Metabolic studies is to measure the serum ammonia, urinary organic acids, plasma amino acids, and blood lactate as lysosomal enzymes in lymphocyte. So, and then the last one that we can investigate is from the neuroimaging. So, what is indication to do the neuroimaging is there is concerning features in the history such as seizures, progressive or degenerative neurologic symptoms. And then next indication if there is abnormal findings on physical examination such as any microcephaly or any focal neurologic deficit. And then if the area is endemic, the area is have a history of exposure to lead, mercury, so we need to do a blood testing for that lah, to know there is associated with lead exposure or not. So the management of ID, the goals is actually to strengthen areas of the dysfunction, to provide ongoing family support, prevent or minimize further deterioration in the child's cognitive adaptive function relative to the peers, and then promote optimal individual functioning in society. Actually, the intellectual disability is not treatable. However, we can give intervention such as supportive care and this early intervention can benefit the children later. So medication is actually not useful. It is useful when there is associated case conditions such as depression. We can give SSRI. If ADHD, so we can use stimulant. Uh, and then if any aggressive behavior, so we can give medication to reduce the aggression. So mainly the management is supportive care. So first is primary care. So primary care, we anticipate the guidance to the children's level of function, such as feeding, toileting, school. So we anticipate the function of the children. So next, primary care that we can give is assess the issues relevant to the child disorder, such as any child function in Down syndrome, because Down syndrome can cause hypothyroidism, and then we can we can give some treatments to that. And then next is multidisciplinary management. So it is multidisciplinary, like from the pediatrician, from the physical therapies, occupational therapies, from the speech therapy. So all of the multidisciplinary management, multidisciplinary approach can help in the development of the children's later. And next one is periodic re-evaluation, because because intellectual disability can children with disability can progress over time. So sometimes they may change over time. So we need to evaluate regularly to know status of the child, status of the disability of the child. And then educational service. So because education is important to all children, so we need to give educational service to the intellectually disabled children. So it is, however, the educational service must be relevant to the child's strengths and weakness, and then according to the child's development and support. So like Afiqah had mentioned before, there is a special education programs for those with disabilities. So it is good for this kind of intellectual dysfunction, the disability children. So next is leisure and recreational activities, because we need to give them to play and happy. So we need to encourage them to involve in recreational activities. Not even they are not competitive, we can give it as a weight management to develop the physical coordination, to maintain the fitness, and to improve their self-image. Next, next is family counselling. So we need to counsel the patient, the family, especially the parents, to help and to take care the children and how to take care. And then there is supports, can use some support groups. And then we treat the associated condition if there is, if any, such as ASD or depressions or anxiety. So we treat it. So the prognosis is generally, for mine, it is basically good prognosis, because it not impairs so much for the daily function. However, for the severe one, so it is very dependent towards other person. So we need to take care more for the severe intellectually disabled children. So what we can prevent to prevent the intellectual disability in children. So we have I classify into primary, secondary, and tertiary. So for primary is to measure to prevent intellectual disability by condition that cause or contribute to ID, such as like we give genetic counselling, such as avoid consanguineous marriage, and then appropriate prenatal care, such as reduce alcohol exposure, ensure the adequate intake of folic acid. And then the next one is prevention of exposure to radiation, newborn screening, for metabolic disease, routine childhood immunization, prevention of poisoning, accidents, violence, and other trauma, and measure aim at reducing poverty, because some of the studies says that low social poverty also can affect the intellectual. Next is secondary prevention, which directing to treat the underlying condition to minimize the risk of impairment in ID. So such as diary restriction for IEM patient, thyroid hormone, replacement if hyperthyroidism, treatment of vision and hearing impairments, and management of seizures and other coexisting medical disorder. Last one is tertiary. Basically, tertiary is to maximize the function and to reduce the functional disability. So it's basically the tertiary one, tertiary prevention is, like I have mentioned before, in the management. So this conclusion, for patient with, for parents with disability, so the Quran said, sesungguhnya hanya orang yang bersabar yang dicukupkan pahala tanpa batas. So we need to take, the parents should husnuzan and take care of their children, because there are rewards, many much rewards that can get. Okay, thank you. That's for me. So reference is Nelson up to date and DSM. Thank you so much.
Okay. Any question to Zafirah? Anyone? Tidur belaka dah. So basically, we are not supposed to use mental retardation anymore lah. Sebab even though if you say mental, actually during my time as a student before 2006, masa tu pun there's already a concern about the term retardation. So we were masa tu basically we prefer to use mental restriction rather than retardation. But then I think the preference is to say intellectual and developmental disability rather than mental retardation. So because stigmatization, as mentioned by Zafirah, and then people calling it retard, you retard. And so all these are quite bad in terms of prognostication for family and things. So that's why I think the term intellectual disability or intellectual and developmental disability is more preferred rather than mental retardation. Okay, the few issues. Yang first thing is we all need to remember that the first thing that we need to identify the risk. Again, to prevent intellectual disability, among the most important thing is to identify the risk. For you to be able as a doctor, we need to able to understand that if you don't manage neonatal hypoglycemia very well, then the risk is intellectual disability. Then if you know the mom has a risk, the mom has diabetes, and then mother is on insulin with very poor blood sugar control, you know the child has risk of hypoglycemia. Neonatal hypoglycemia, among the problem is intellectual disability. So these are the things. So identifying the risk is very important. Early intervention program is another very important issue. So we need to start from very early on. So children like those with Down syndrome, those with other syndromes as well. So it is very important for us to get the proper early intervention program. Down syndrome, if we do proper intervention, if we do proper physiotherapy, proper program, they can achieve a lot in life. Rather than we leave it, we don't do anything. So the more we can offer to the children, the more they actually can achieve. Again, for the family, I think it's very important. The last few slides that Zafirah has mentioned, the acceptance of the family and things. So we usually say lah. So like if what I usually say to parents kan, maknanya if you have normal child, so you may be happy that the child looks normal, looks cute and whatnot, but then you don't know whether the child is actually will go to heaven or go to hell. So you don't know what's going to happen with these children. Are they going to be useful to human being or are they going to be a scum in the earth? Kita tak tahu dah anak tu pergi mana. Dia pergi syurga ke neraka ke, dia bawa these children, are they going to pull the parents to heaven or hell. But your children with this intellectual disability, these are the children that are confirmed their place in heaven, and these are the children that may pull the parents to heaven as well. But the thing is, it's easy to say, but it's not easy to accept. You can say it easily, tapi bila nak terima, even for yourself, it's very difficult. So I think this is one thing that we need to remember. And then again, the issue about multidisciplinary approach is very important. Multidisciplinary and community approach is very important. Okay, we have already passed 2 hours, isn't it? Okay, we have one more presentation, kan?
Yes, Dr.
Larat lagi ke tak larat dah? Boleh lah laju-laju je lah. And then yang extra class tu, I think kita kena reschedule lah. Kepala kan. Okay, so okay, let's proceed.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. So my name is Aqilah binti Yunus and I'll be the last presenter for today, and I'll be talking about palliative care in the context of pediatric patients. So this is the outline of my presentation. First, we'll discuss about what is a definition and also principle in palliative care, and then who actually needs palliative care, what type of PEDS patient needs palliative care, and also who will provide palliative care towards this patient. And then we look towards death in the child's perspective and proceed with symptoms management and also end of life care. Okay. So according to the World Health Organization, palliative care can be defined as the active, total care of the child's body, mind, and also spirit, and not only limited to the care of the patient itself, it also involves giving support to the family members. Optimally, this palliative care should begin when a life-threatening illness or condition is diagnosed and continues regardless of whether or not a child receives treatment directed at the underlying illness. So the goal of palliative care is to actually improve the quality of life of the patients and also the family members, as well as maintaining the dignity and also ameliorating the suffering of the seriously ill child. So how do we do this? How do we improve the quality of life of the patients? It is actually by facing the problems which is associated with the life-threatening illness through prevention and also relief of suffering. So how do we do this? By means of early identification and also assessment of patients' symptoms such as pain and other problems involving the physical, psychosocial, and also spiritual aspect. So what is the difference between palliative care among adults and in pediatric patients? So first, because they vary in the cognitive abilities and also emotional maturity of the child, also adolescents, because we know the pediatric patient actually encompasses from children up until adolescent. So these ages are varied ages, so they have varying cognitive abilities and also emotional maturity. And also, what's the difference is that the difference in the causes of the life-threatening itself, the type of disease in which this pediatric patient has compared to adult patient. Another thing is the difference in emotional and psychological issue regarding the seriously ill child. And apart from necessity to deal with the child, we also need to deal with the parents and in some families, even siblings who are affected by the illness that a pediatric patient has. And in this case, in pediatrics context, the authority of decision making about patient's care resides with the parents and not the child, because we know children has no eligibility to give consent. Next, we'll go to the question, who needs palliative care and what type of patient actually needs palliative care in pediatrics context. So the first one is in the condition for which curative treatment is possible, but it may not succeed. For example, in the case of advanced or progressive cancer or cancer which has a poor prognosis. Other examples in the case of a complex and severe congenital or acquired heart disease, in which in both of these examples, the curative treatment is available, however, it may not succeed in some patients. So the second condition in which patients need palliative care is whereby in patients who have the disease in which the condition has intensive long-term treatment. However, the treatment is aimed only at prolonging life and maintaining the quality of life, because in this kind of disease, we know that premature death will persist or is still possible. For example, in the case of HIV infection, cystic fibrosis, in the Nelson, it mentions that for cystic fibrosis, for example, the life expectancy will be for about 37 years old only if they did survive to adulthood. But most of them may also die in the early age due to multiple morbidity. Apart from that, it can also be due to severe immunodeficiency, chronic or severe respiratory failure, and also muscular dystrophy. For example, the Becker's muscular dystrophy and also the Duchenne muscular dystrophy. The third condition in which patients need palliative care is when patients is diagnosed with a progressive condition for which there is no curative option, in which the treatment is almost exclusively palliative after diagnosis. And the disease which is classified under this condition is mostly a genetically determined disease which is progressive in nature. For example, the progressive metabolic disorder such as mucopolysaccharidosis and also Tay-Sachs disease. So what is mucopolysaccharidosis? Basically, it is a group of metabolic disorder which is caused by the absence of lysosomal enzyme needed to break down GAG, or we call glycosaminoglycan. So glycosaminoglycan is actually a long chain of sugar in which when there is defective breakdown of this sugar, it will precipitate in the cell and thus impair cell function. And in Tay-Sachs disease, it is also a type of genetic disorder due to genetic mutation in the hexA gene, in which the presence of this hexA gene mutation, which codes for hexosaminidase enzyme, when this enzyme is defected, it will cause build-up of molecule GM2 gangliosides within the nerve cells, and thus it will further cause disruption of nerve cells in both brain and also spinal cord, and it is a progressive condition. And other example of disease which is classified under this condition is Batten disease. And Batten disease is also a genetically determined disease, autosomal recessive in inheritance, which is a type of neurodegenerative disease also. In the early stage, early signs of patients with this Batten disease may be subtle. For example, personality changes or behavior changes or even slow learning or regression. But over time, these affected children can have mental impairment, may have seizures, worsening seizures, and progressively loss of sight and further neurodegenerative manifestation. Other example is the severe form of osteogenesis imperfecta. In this condition, in osteogenesis imperfecta, there is reduce of type 1 collagen normally present in the joints in the bones. So with this defect, patient is susceptible to multiple fractures. And the condition
do you know any movie where the protagonist has osteogenesis imperfecta?
I'm not
Hollywood
sure.
movie.
Tom Hansen.
Unbreakable.
Forrest Gump.
Forrest Gump osteogenesis imperfecta ke?
Unbreakable tu.
Unbreakable, yes. Okay.
And the fourth condition in which patients need palliative care is whereby a patient is diagnosed with a condition which is non-progressive. However, it causes severe disability, which causes extreme vulnerability to the health complication. For example, in the case of severe cerebral palsy with recurrent infection, and also in the case of severe neurologic sequelae following infectious disease, in case of hypoxia or anoxic brain injury, and also brain malformation such as holoprosencephaly or lysencephaly. So these are the example. You could classify the disease according to these 4 conditions. So we have already identified which type of pediatric patient actually needs palliative care. So the next question will be who provides this palliative care. So palliative care is actually needs a multidisciplinary team of healthcare professional. It involves interdisciplinary approach that may include nurses, physicians, psychiatrists, psychologists, social workers, and also chaplains or religious institutions at times. And this pediatric palliative care, which involve multidisciplinary team, the aim is to give a broad range of expertise to patients and also families, as well as to provide a supportive network for the caregivers. And this pediatric palliative care should be provided across settings, in which it involves in-hospital care, outpatient settings, in-home, pediatric nursing facilities, and also inpatient hospice house. So in Malaysia, we have this Hospice Malaysia, which is a charitable organization which provide professional community palliative care to those with life-threatening illness. So this Hospice Malaysia is actually based in Jalan Ceras, KL. So it provides palliative care mainly towards the patients who live in the Klang Valley area. So you guys can visit the Hospice Malaysia website, and also you guys can buy this merchandise to help find Hospice Malaysia. So you guys can visit the website. And next, we will look at death in terms of child's perspective. So in pediatric patients mentioned, it encompasses since newborn up until adolescence age, right? So in these varied ages, patients or child has actually different we say cognitive level. So from months to 2 years old, they are categorized as having sensory motor in the sensory motor phase. From 3 to 5 years old, they are in the pre-operational phase. 6 to 12 years old in late pre-operational to concrete operational before they enter the formal operation stage, starting from 12 years old onwards. So, how do child who are newborn to 2 years old, how do they perceive death, right? So since they are in the sensory motor phase, they have limited understanding of the events, future and past, and also they cannot tell the difference between living and also non-living. So they may be confused or perplexed when they see their parents crying. They will say like, "Mommy, don't cry," and there's probably no concept of death like in this kind of patient. So they will be like, "Daddy, will you still tickle me when I'm dead?" Because they don't get across the concept of death itself. So in this phase, our strategy and response should be to optimize comfort and also consistency, maintain a familiar person's objects and also routines towards the patient so that the patient feel that they are constantly being in comfort. We may use soothing songs, words and also touch, and practice words like "I will always love you," "I will always take care of you," and everything. Next, at the age of 3 to 5 years old, they are in the pre-operational phase. So this phase is also sometimes called the magical phase, because in these kids in this age, they actually their concepts of death are simple and also reversible. They have variations between the reality and also fantasy, in which therefore they are caught sometimes in the magical phase because they cannot really differentiate between reality and also fantasy. But in this kind of patient, in this age, kids actually perceive death as a guilt or as a punishment, because at this age they have developing the sense of guilt. So they may feel responsible for the illness that they have. So they may say something along the line like, "I did something bad and so I will die," and everything. So in this age, as a caregiver and also as family members, we have to assure the child that this illness is not the child's fault, and we should provide consistent caregivers and promote honest, simple language. And we may also use books or other medium to explain the life cycle and promote questions and answers. So we should emphasize like "You did not do anything to cause this, you are so special to us, and we will always love you." And next, in the age of 6 to 12 years old, from here they start to basically grasp the concept of death. The child begins to demonstrate organized logical thought. However, the abstract reasoning will be pretty much limited at this age. So they begin to understand death as real and permanent. To them, death would mean that your heart stops, your blood does not circulate, and you do not breathe. It may be viewed as a violent event, so they may be quite scared of death. They will ask, "How will I die? Will it hurt? Is dying scary?" And so in this phase, we should be honest and provide specific details if they are requested. And we have to support the child's need for control in this situation. So we can say something along the line that we will work together to help you feel comfortable. It's very important that you let us know how you are feeling and what you need. We will always be with you so that you do not need to be afraid. And then starting from 12 years old onward, they have been in the phase of formal operation. So in this age, they already have abstract thoughts and logic is possible. They understand that death is irreversible and inevitable, but they have a constant need of reassurance, of continued care and also love. And at this point of time, since they started to have abstract thought, they would be having the intuition to search for meaning and purpose of life. And they usually live intuitively based on altruistic values. Like they know they have to stay alive for their family. And if even they die, they maybe wanted to donate their organs or tissue. In these patients, their questions may be along the line like, "I'm afraid of die. If I die, my mind will just break down. What is God letting this happen and everything?" So in this phase, as the caregivers and also the healthcare providers, we should always discuss with the adolescents regarding their wishes, hopes, and also fears that should be attended to and respected. And also we have to reinforce child and also adolescent self-esteem, the sense of worth and also self-respect. And also we have to tolerate if they did express strong emotions during this phase and permit their participation in decision-making regarding their own illness. So,
Aqilah,
yes.
I just wanted to add few more things. Sometimes if you here in UAE we don't have our pediatric oncology ward, but I've seen children sometimes because I look after the hemato-oncology ward in USM for quite a long time, many months I've looked after them. So I still have some of my oncology patients that still contacted me by WhatsApp and things. So sometimes these children kan bila dia tengok one by one their friends in the ward, because sometimes bila oncology patient bila dia masuk ward they stay for months kan. Children yang dia dah kawan main sama-sama and then one by one die. So we can see how they think. So even though and then they know that at the time will their time to die come soon ke macam mana. So even in children we do need to acknowledge them. Kita tak boleh just cakap dengan parents saja. Kita kena acknowledge their feeling, kita kena acknowledge that they actually understand this issue. I've had one patient before, boy, 10 or 11 years old, not even 11 years old lah. He has AML, acute myeloid leukemia, relapse AML. So I was there when we first treated him with AML, sort of goes into remission and then relapse again. So masa relapse tu memang problem lah. So we basically the plan is to go for palliative care. So one incident yang I did remember very clearly was one morning when we were going to do rounds on this patient. Masa tu was among his last few weeks lah sebenarnya. Dia dah in relapse, lepas tu dia pun quite unwell, dia down with febrile neutropenia. Tapi dia still cheerful, still alert, still very talkative. So when I was doing rounds, masuk kat tempat dia, I saw this child was reading one book. You know what book he was reading? Dia baca satu buku, topik dia is menghadapi kematian. This is an 11 years old boy. 11 years old boy baca buku menghadapi kematian when he is actually at his last phase of life. Can you imagine? So I think when we saw what he was reading, I still remember this child very clearly. Each time I think about this child, saya pun rasa macam I felt like crying myself. Maknanya, how this 11 years old boy, he knows that his time is coming, and he's reading that book, and dia pesan buku ni nak kasih pada which friend, barang ni dia nak kasih pada kawan siapa. So he thinks about others. So can you imagine this 11 years old? Kalau kita dulu kan, umur 14 pun apa benda yang kita fikir kan. So my point is sometimes do not underestimate children. So they may be small, they may be, but their mind sometimes really will be surprised with what they can do and what they can think. Another interesting thing for me to share in terms of how a child sees death. Okay, I have 5 children. My eldest is now 14. So dulu I used to work in Muazzam, and my family lives in Kuantan. So I usually macam bila on call I'll stay in Muazzam, but then if I'm not on call then I'll macam balik hari kan after work, then I'll come back. So there was one time I forgot that I'm on call. So sometimes I bring my son tu berapa I think 3-4 years old lah. Sometimes I bring my son to clinic, so he joins my clinic and things. But then I forgot they changed the time, they changed the rota, and actually I'm on call. So when I'm on call, my son needs to be with me. Kan? So maknanya my son needs to be with me for 36 hours in the hospital. So that night, when obviously we don't bring any other extra clothes, so he's wearing the same clothes for 36 hours. So that one night, there was one patient collapse in the ward. So obviously pukul 10 malam, I cannot leave my son alone. So I bawa my son, resuscitate this patient, dia tengok kat belakang. And he saw me resuscitating this patient, and then actually the patient died. So and then I saw, this is a child of 3 or 4 years old, but despite him being a small child, he understands that this is a major event. this is an event that needs empathy. So he was able to show empathy to the family. Dia tak main-main, dia tak bising-bising, he shows empathy. He understands that this is a huge event, and he was able to show empathy and things. So I think the point I'm trying to say is, even though the children are small, they actually can understand this sort of issue. So especially if they involve the child, more so kita kena involve them together as well. Okay, all right, proceed.
Okay, so next, when we talk about palliative care, it may seem like a subjective concept, right? However, these are the elements of palliative care basically. First would include the pain management. Second is the expertise with feeding and also nutritional issues. Third will be the management of common symptoms which presents in patients needing palliative care. So first, for pain management, in order to identify pain that patients have, we have to do regular pain assessment throughout the course of treatment. And our aim is to initially prevent pain, however, which is inevitable, we try to reduce and also control the pain. And these measures will include both non-pharmacologic and also pharmacologic measures. By using the WHO analgesic ladder approach as a guideline. So in this WHO analgesic ladder approach for pediatrics, we see that for a mild pain, we start first with non-opioid. Non-opioid could be ibuprofen or paracetamol in patient aged more than 3 months old. However, in patients less than 3 months old, we'll opt for paracetamol only. And then we will step up the medication for pain if pain persists or increases, and we will include any strong opioids, for example, morphine or fentanyl, oxycodone, hydromorphine. And we can also include adjuvant, for example, antidepressant, anticonvulsant, and others in order to relieve patients' pain. And sometimes patients in palliative care, since they sometimes in some patients, they don't really have active movement and they may confine into bed, so they are more prone and higher risk to get constipation. So we can also consider to give prophylactic laxative to avoid constipation and thus to reduce the pain that patients has. And as a matter of rule, we should avoid unnecessary painful procedures in palliative care patients. We should also administer adequate doses of analgesics by the clock. By the clock means not only after patient has pain only we give the analgesic, but we tailor the doses of analgesic and also the timing or the frequency according to the drug's half-life by itself in order to prevent pain. We should give sufficient dose and an appropriate pharmacological formulation should be chosen to enable children and also their family to sleep through night without waking in pain in order to improve their quality of life. So this is generally pain can be divided into nociceptive pain and also neuropathic pain. In nociceptive pain, it is due to the signal sent to the nociceptors due to pain which is inflicted at the organs or at the skin, joints or bone surfaces. And meanwhile, neuropathic pain will be caused by dysfunction in the nervous system or neuron itself, damage to the nerve itself, which cause neuropathic pain. So in these cases, both of these cases, we can go for non-pharmacology and also pharmacological management. And for non-pharmacology may include relaxation. We could reduce the noise or relax patient by using music or guided imagery, and also even physical contact will provide relaxation to the patient. We can also try to apply local hot or cold application and also other comfort measures. And for pharmacology for nociceptive pain, we can use analgesia as mentioned earlier, and also includes other adjuvant. Meanwhile, for management of the neuropathic pain, the non-pharmacological management will be pretty similar to the nociceptive pain. However, in the pharmacological management, the medications that we use is quite different. That is, for example, anticonvulsant, antidepressant, capsaicin cream, or lidocaine, or even steroid use. And next, the second element, apart from management of pain, we should also manage other common symptoms which is present in patients needing palliative care. So also, in order to treat this symptom, we have to recognize first, and this will need assessment, regular assessment of the child, not just physical symptoms, but also involve psychological, social, and also spiritual aspect. So the core principles of the symptoms management in this palliative care patient, first is to treat the underlying cause. How do we treat this? We can use pharmacological and also non-pharmacological, and also involve behavioral therapy and also supportive therapy. And any persistent symptoms, we should treat with regular interval medication in order to prevent the symptoms from developing. And in cases of severe and uncontrolled symptoms, they should be regarded as medical emergency and also needs active intervention. And as a matter of rule, again, avoid inappropriately invasive and painful routes of drugs and drugs administration. And we should also observe and also monitor for the side effects of medication in these patients. So next will be just the common presenting symptoms in palliative care patient, and it is actually quite detailed. And for each of these, the principle is that in any presenting symptoms, for example, difficulty breathing, we should find the underlying cause or the principal causes. For example, in difficulty of breathing or dyspnea, it could be lung causes, cardiac causes, extrathoracic, or even psychological. And so the main principle is to treat the underlying causes, and then the management will further be divided into non-pharmacological and also pharmacological management. So for the details, you guys can read later, because these are among the common presenting symptoms. And next, we'll talk about end-of-life care. End-of-life care means that the care of patients who we anticipate death to be near, which death is coming to the patient. So how do we manage end-of-life care in this palliative care patient? First, we manage the symptoms that is present at that point of time. And apart from that, we should prepare onwards. We should have ongoing preparation and also support. For example, we could discuss with the family members and also the patient itself regarding the selection of a preferred location of death. And also, we should also discuss earlier regarding whether we should do autopsy or even if the patients opted for organ and tissue donation. So these issues should be discussed earlier prior to patient's death. And apart from that, it does not only concerns before patient dies. This care also extend beyond after the patient died with provision of bereavement, or we can also give grief work for the family members who are affected by the patient's death. And so these are my references. So when we are thinking of palliative care, we should think what can we offer that will improve the quality of this child's life and provide the most meaning and control for their family, instead of just thinking what therapies are we no longer going to offer to this patient. So we should add more life to days that the patient had, instead of just adding days to the life of patient. So with that, that's all for my presentation. Thank you.
Any questions to the examiner? To the presenter? I know it's already 3 hours. Any question to the presenter? So pediatric palliative care is very, very new. Do we have many pediatric palliative care patients? Yes. Like last week, we have patient with Edwards syndrome, for example. Edwards syndrome is one of the syndromes where we should go for palliative care. Palliative care is by no means meaning kita neglect the child. Palliative care by no means bermaksud kita angkat tangan, kita biar the patient to die. No, palliative care doesn't mean that. Palliative care means kita we give comfort care to the patient. Comfort care, we allow the child to go in comfort. Kita bagi adequate painkiller, kita allow the child to go in dignity, preserving the patient's dignity. So ni benda-benda dia. Bukannya, patient palliative care kita ignore, tak ada kat tepi. No, bukan. Kita still cover, kita still treat dia, but kita jaga dia punya dignity and kita allow dia go in comfort. So the idea is comfort care for the patient that's dying and also comfort care for the family. Contohnya kalau patient is dying, janganlah letak dia dekat open ward. Mungkin kita letak dia in a room where the child can die peacefully with the parents. Tak ada parent lain yang tengok-tengok, glance on them, stigmatize them. Tak ada. So these are among the things yang kita nak kena. So palliative care is fairly new. I'm not gonna discuss more sebab kita pun I think 3 hours for session is too long lah already. Another thing that I wanted to stimulate you guys to think is Islamic aspect of palliative care. So the issue that I am having now is actually we don't have enough Islamic punya group NGOs that help for Muslim patients. Kan? So it doesn't reflect well. So I think among the things that kita as Muslim kena push is our probably Muslim punya Islamic hospice, Islamic respite center, for example. So kita nak okay, I give you one scenario. if kita na'udzubillah, if kita involved in an accident and we were about to die, would we like to have a doctor who can help us to say the prayers, bantu kita untuk mengucap syahadah ketika di hujung hidup kita? Kita nak tak ada doktor tengah buat CPR, dia boleh panggil family member datang and ucapkan syahadah masa buat CPR? Obviously kita nak. So these are the things yang I think kita nak kena train ourselves lah. So us, you all semua as future doctors, you need to remember that people that are dying, they have their dignity, they have their religious preferences. So we need to come and help them. Kan? Sometimes, for example, ventilated patient lama. Sometimes bila dia nak at the end of their life, kita still continue with very high doses of sedation. They die being sedated. Kan? Some people dia prefer apa? Dia prefer kita reducekan sedation dia and kita try to extubate. Sebab apa? Bila kita reduce sedation, dia boleh regain dia punya conscious level. So at least before dia pergi, dia boleh jumpa dengan family member dia, bagi pesanan-pesanan apa yang dia nak sampaikan dan sebagainya, kan? So I think these are the things that kita nak kena fikir. Muslim Islamic palliative care is something that I think is extremely lacking in our ummah. So I think there's so many things to do. I really hope that you guys can think about this and continue thinking about this even after you all become doctor nanti. Because there's so many things to do. This is a huge jihad that I think we need to do. Yeah, the ummah needs our help, needs our care. Among the measures yang kita buat, we are doing now in IUM Medical Center is clinical spiritual care. So we are doing Islamic clinical spiritual care for our patients. So sekarang ni kita ada, we are still in the period of training our staff. So kita nak make sure we can give not just clinical support, clinical care for our patient, but also Islamic spiritual care in a clinical setting given by clinicians to our patient. So these are things that I think there's so many jihad that we need to do. It's not just a matter of treating this disease, bagi PCM, bagi morphine, bagi apa semua, but we need to input our care in terms of the healing the inner self of the patient as well. Okay lah. Alright, I think this is too long already for us to continue anymore. I promise one of you, siapa promise to have a teaching session, extra teaching session, Afiqah kan? I think kita kena rearrange lah. I'm very sorry lah. I think tak sempat lah. Petang ni pun kita orang ada meeting. But again, I don't mind. Nanti you tengok bila time yang siapa-siapa you all semua tak ada session with other lecturers, contact me again lah. I don't mind malam ke anytime weekend. It's okay for me as long as you are free. And then you can confirm balik. I also have some meetings at night as well. Okay, alright. I think let's stop here. Let's end our session with tasbih kafarah dan surat al-Anfal. Okay, Assalamualaikum.
Thank you, Doctor.
Thank you, Doctor.
Betul.
Thank you, Doctor.